today. I have a few announcements before I introduce our speaker this morning. First, we're accepting applications for our CPE program for interns, which begins in September 6th. So if any of you are interested in clinical pastoral education, or you know of anybody who would be, feel free to send them to our website or have them reach out to me. Second, please mark your calendar for our next Grand Rounds presentation, which will occur on Friday, June 17th at 9 a.m. That will be our final presentation for the academic year. We'll take July and August off, and then we'll resume in September. I'm so excited to welcome our guest for June, a friend and colleague of mine, Chaplain Joel Burning from New York Presbyterian Hospital. His presentation will be on picture-guided spiritual care for patients with mechanical ventilation. He and a number of his colleagues at New York Presbyterian conducted some research that resulted in a paper in the Annals of American Thoracic Society on that topic. It's not something you'd want to miss. Also, this event is approved for CMEs, both for physicians and CEs for social workers. So make sure that you sign in if you haven't already, and please make sure to return one of the evaluation forms at the end. And finally, chaplain residents and chaplain fellows, please remain here in the Stern Auditorium following the Grand Rounds for a follow-up discussion afterwards. And now a few words about today's guest speaker. Dr. Christina Puchalski is a pioneer and an international leader in the movement to integrate spirituality into healthcare in both the clinical setting and in medical education. As founder and director of the George Washington Institute for Spirituality and Health, also known as GWISH, at the George Washington University in Washington, D.C., she continues to break new ground in the understanding and integration of spiritual care in healthcare. The spiritual assessment tool called FACP, which she developed, is used widely in clinical settings around the world. Medical education has been impacted in this country by a GWISH-run awards program in spirituality and health. GWISH has convened groups resulting in models and recommendations for multidisciplinary spiritual care. Dr. Puchalski is the co-leader of the recently formed Global Network for Spirituality and Health. She's the professor of medicine and health sciences at George Washington University School of Medicine. She's an active board-certified clinician in internal medicine and palliative care. She's a fellow of the American College of Physicians, the American Academy of Hospice and Palliative Medicine, and a member of Alpha Omega Alpha Honor Medical Society. She's won numerous awards, including the George Washington University Distinguished Alumni Award, the Outstanding Colleague Award from the National Association of Catholic Chaplains, and the Distinguished Service Award from the Association of Professional Chaplains. This morning we're delighted to have her here with us to speak on the topic of advancing whole person care, curricular development in spirituality and health. Ladies and gentlemen, please help me welcome Dr. Puchalski.
Thank you so much. It's a pleasure to be here, and I just wanted to get a sense of who's in the audience. I imagine there's a number of chaplains here. How many chaplains are here? Great, that's wonderful. Any physicians, nurses, social work, great, counselors, physical therapists, PTOT. How about people interested in or who actually do medical education with medical students? Okay, wonderful. So I'm going to give an overview of some of the curricular initiatives that we've been involved in and others over the years in creating curriculum in spirituality and health. And you'll see that there's two main aspects to that. One is for what's involved in patient care directly, like doing a spiritual history, but the other is about our own formation of medical students, which is something we've been more involved in over the recent years. So if we look at, people always say, well, what is spiritual care? Is that religious care? Is that cultural care? Is that only in the domain of chaplains? So really looking at spiritual care is something that we all on the team do. And that's spirituality broadly defined. Transcends the control of disease process and the relief of symptoms. So it's really looking at the whole person, that we recognize that psychosocial, existential, social, spiritual, emotional distress can be as great, if not greater, than physical distress. So we have to be, all of us need to be aware of all of the domains of the whole person. It also has to do with full health. So in medical education these days, wellness, fortunately, is a big topic, and looking at spirituality not just in palliative care or in end-of-life care or in disaster or stress, but also in health. How can we have full health? So I'm always in discussions when we talk about wellness programs about education, nutrition, etc. We also need to include emotional wellness, social wellness, and spiritual wellness as well. And it goes to the underlying principle of spiritual care, which is good medical, nursing, and full care, is honoring the dignity of every person, regardless of their abilities, their backgrounds, their gender, their age. We honor the whole person. All people get dignity. So I also, while we were developing, so I started this work in the early 90s, but at the same time there were other efforts in the 90s and through up to the present trying to change medical education. So humanities, Rita Sharon from Columbia is huge in literature and medicine. The whole area of humanities has become much more prominent. One of the inspirational factors for me to start a course on spirituality and health was that in my doctoral program in biochem, we were required to at least have language and some courses in humanities. And when I worked at NIH, I recognized a lot of patients, their stories were much more than their disease stories. Then I go to medical school and there's nothing, no courses on humanities, everything was pure science, clinical science. And so I felt it was really important that we add something. Of course, now medical education has changed. We have a lot on humanities, integrative medicine is very important. Chachanov's work, dignity-centered therapy, your colleague here in New York, Bill Breitbart, on meaning-oriented therapy, wellness I mentioned, the whole theme of compassionate care. How do we provide compassion? How do we express care at the same time, and compassion deeply, at the same time being reductionist and doing our job as nurses and doctors and others. And then, of course, palliative care and family medicine are two fields in which this has been an ongoing interest and requirement in those fields. I wanted to just highlight this in terms of a story. This was a patient of mine who was 88, and she was just coming to me. Let's say that she was coming to someone she hadn't seen before, primary care doctor and a physician, to talk about the results of her breast biopsy. And she had triple-negative breast cancer, which means that she didn't have any receptors on those cells that would make it more amenable to target therapy. So not a great prognosis for someone her age. And for others as well. I mean, there's other things you can do, but you always want to have, if you have triple-negative, that's not a great prognosis. So options for treatment are surgery and then chemotherapy for her. And the breast surgeon, of course, was worried about her age and wondering, what should we do? We need to find out if she wants surgery, and so she asked me to do goals of care, more of a palliative care visit. Now, if it were sort of a traditional kind of note, and many of us do this when we're rushed, is very physically focused. It would be a little bit more than this, but we would talk about our medical conditions, a little bit of cognitive impairment, hypertension, hypothyroidism, the goals of care to have surgery and remove the tumor, that we had explained the limited treatment options for triple-negative breast cancer, risks of the procedure were explained with the prognosis, and we'll proceed with the metastatic workup and then plan for mastectomy and sentinel node biopsy, pending that workup. So that would be the end, and that's what we often read. I still read these things, and sometimes when I'm rushed, I have to admit, some of my notes are a little briefer as well. But it really doesn't tell the whole story of who this lady is, so it's hard for people to understand who that person is other than her diagnosis. Well, it just so happened she was from Ghana, and she loved helping people. She came here a long, long time ago, was a nurse in her own country, so very well educated, but then worked in a nursing home when she came here as an immigrant and cleaned floors, and then eventually became like a nurse aide. But it was very important for her to help others, and she doesn't want to be a burden. She doesn't want her son and her family taking care of her. So she says, I know this is serious. So she was very aware of her cancer. Her faith, she's Catholic, active in her church, it guides her decisions, and meaning is in family and service. So that gives you a little bit bigger picture. And part of what we are trying to do in this whole area of spirituality and health is to encourage people to write a narrative. So I was just in Tampa, and the chaplains there have a wonderful acronym, which I'm now blanking on in a minute, which has to do with a chaplain note. And the first part of it, it's called news. The first part of that acronym, news, narrative, is writing a narrative. And I think we also, doctors and nurses, should be thinking about the narrative. In our note, probably the best place for that is the social history. So you'll see as we evolve this education that a lot of the inquiry about spirituality is within that patient-centered social history. My colleague and friend, Reverend Margaret Gunther, who's an Episcopal priest and very well known as a spiritual director, her doctorate, she's in her 80s now, but her doctorate was from Harvard in German literature when she was in her 20s, so she's quite a remarkable woman. She's talked a lot about deep listening. And what she says is you don't really know who the human person and being is, the full depth of the person, the soul. You don't know who that person really is, and so you listen. What you'll hear during my talk is how, in addition to teaching content in spirituality and health, we need to teach listening skills. And I'm going to end with a program that we're now doing called Reflection Rounds, in which we're teaching that. And listening is more than, who are you? Tell me about your medications. What are your allergies? Are you married, single? Are you sexually active? What's your gender identification? What kind of work do you do? I mean, that's getting information. But listening is really listening to that depth of that person. And ironically, most of what we do when we really listen is to be silent. So it's a huge part underlying this curricular activities. If you're thinking, I know a lot of work has been done here. Mount Sinai was one of our award winners. A lot of work has been done here at Mount Sinai in spirituality and health curricula. And as these courses have evolved, we've recognized the need to do these kinds of listening skills. So it's more than hearing and repeating to the patient what they're said. They said it's really listening at a very deep level. So we're blending a narrative model and a medical model. And this is where I've been so honored to work with chaplains all these years. And that I think our trainings match, actually. I think we complement each other. And that chaplains, fortunately, don't have a really reductionistic curriculum with learning objectives, and that's all they do. Fortunately, there is the CPE training, which is very focused on narrative and on listening to the whole person and learning that deeper listening than we often do. So that blending of our skills is so important. And you'll see again in reflection rounds that we have that co-led by a chaplain and a physician. So how do we really listen to the patient's story and make sure everyone on the team is doing that? And what do clinicians need to be able to do that deep listening? That's a huge piece of the medical education. So spirituality, broadly defined in health, I think is the area where we open up to those deep conversations with patients. Not always. It's patient-led, so we can do a spiritual history, and if someone doesn't want to talk about it or just wants to talk briefly, that's fine. But it does give an opportunity, if done correctly, to really open up to that deep conversation. Spirituality, for those of us that are clinicians, is that part of us that leads us to that capacity for compassionate presence. And I understand that there's some discussion here about detached concern, which is an interesting terminology. I think another level is compassionate presence. How can you be fully present to someone that's suffering and at the same time know when to move into other parts of your encounter? Now I'm talking about physicians and nurses and the other parts of our encounters that we have to do. I'd like to share with you a definition, a global definition of spirituality. So in this area, it's one of the perhaps most contentious areas, or most areas where we get debate and question is around the definition of spirituality. So when I first started this in the early 90s, people were afraid that it would be a religion course and that it would be an opportunity for, say, discussion about one particular type of religion and maybe some proselytizing. People are very nervous about that, not just in the US, but globally. And so it was very important for us to achieve consensus on definitions. I will in a minute share you what happened with AAMC in the 1990s. But since then, we've done a lot of clinical work. I won't talk too much about that today. I'll just allude to it a little bit because that it does impact the content of the courses. But it was really looking at spirituality in a very broad way. What is spirituality in people's lives? And so this came from based on a consensus conference we did in 2009 here in the States, and then one in which we know we've been looking more at policy changes in healthcare systems where we can integrate spirituality into care. So spirituality is dynamic and intrinsic aspect of humanity. Everybody has that, everyone. Regardless of what their backgrounds are, everybody has that. And it's a way that we seek ultimate meaning, purpose, and transcendence. So how we understand transcendence, something outside of ourselves, whatever that is, does not have to be religion. Ultimate meaning, I really actually love that term. We have that in the medical school definition as well, WMC. It was not in our national definition of the consensus conference, but if you think about ultimate meaning, as we move through our lives, whether it's aging or illness, and we're starting to face the end of our life, there may be things that have given us meaning throughout all of life that we can no longer do. Or maybe family, loved ones, and they've all preceded us in death. So we are no longer capable, or maybe we have a disability where we can't do the things that used to give us meaning. So what is that sense of ultimate meaning as we're facing our mortality? And I found it interesting, just as an aside culturally, because most of the people at this meeting, there were 35 countries represented. Many of them were from Europe, just because the conference was in Geneva and it was easier for them to get there. And by and large, Europe is not a religious country. And there's a lot of suspicion about religions. I thought it was very interesting that ultimate came up, that terminology, as well as transcendence. So one is that intrinsic part of us that seeks meaning and purpose and transcendence. And then the other is the experience that we have either to our inner self, to family, others, community, society, nature, and thus significant or sacred. So we often talk about meaning and connection to the significant or sacred, however people understand that. The global group wanted to add the last definition: spirituality is expressed through beliefs, values, traditions, and practices. So in terms of education, as I alluded to at the beginning, there are two, say, categories. One is about patient care. So doing a spiritual history or a screening, it depends who on the team is doing that. And I'll talk about that in a minute. Identifying spiritual distress as a diagnosis and then treating that. And so I still hear people saying we have a chaplain on the team, they can diagnose. That is true. But we are the first people, often the physicians are the first people, and nurses, when we talk about bad news, when we encounter a patient. So we also need to be thinking about a potential diagnosis. And of course, working with chaplains to confirm our diagnosis or to treat it. That's the model. Generalist, specialist, with the chaplains, trained chaplains being the specialists, and others of us being the generalists. We have to think about a whole person assessment and treatment plan, the biopsychosocial spiritual model that is so fundamental. It is the foundation of palliative care, with palliative care being defined as from time of diagnosis, but also family medicine and others when we look at all four domains of care. And then our presence to that person's suffering. Now the student resident clinician formation is an inner life focus. You know, what gives us meaning? How can we help our students reflect on their meaning and purpose, their vocation, their call to serve? Where does spirituality enter into authenticity? Who they are as authentic people. I've been really pleased that since we've integrated a personal professional development track in our medical education, I hear many more students now, or maybe it's the society, I don't know, but the younger students coming in, very open about who they are, what they're struggling with. Not embarrassed to talk about any aspect of their life, really wanting to be authentic individuals. And then, of course, to be compassionate to others, we need that to ourselves as well. In the 1980s in this country, there were courses in ethics and religious traditions, predominantly at religiously based schools. In 1992, we did a formal elective, the first that we know of in spirituality and health, more broadly defined. 1995, John Templeton Foundation began an award program, Spirituality and Health. 96, we actually applied to that award and integrated our course into the required GW curriculum. In 1999, with the Association of American Medical Colleges, we did a consensus conference around this topic. I'll share the definition and the overall outcomes for that. In 2004, we had a compendium survey of 102 schools showing that about 70 to 75% of schools have topics related to spirituality and health. The ideal, if you will, when we were working with WMC, the way to ideally teach this is through an integrated curriculum. So you may not have a standalone course, which makes it a little hard to do surveys, but you will have topics integrated into a larger part of the curriculum. 2009, we did interprofessional spiritual care guidelines and then the national competencies in spirituality and health education. And since 2011, we've been doing the Jewish Templeton reflection rounds. So the definition from the AAMC, you'll see, mirrors the global definition to some degree. It's recognized as a factor that contributes to health in many persons. It's a concept that's found in all cultures and societies. It's expressed in an individual's search for ultimate meaning through participation, religion, and or belief in God, family, naturalism, rationalism, humanism, and the arts. So there's many, many ways that people come to understand that meaning and purpose. What I like about this particular definition is it brings it down to Joe O'Donnell, who's part of our consensus conference. He's up at Dartmouth. How do we, as clinicians, understand health and illness and our own meaning and our own meaning and purpose, and how do patients do, and how do we interact with one another coming from that? So, in terms of our overall outcome goals that came out of this conference, it's to be aware of the need to incorporate spirituality into the care of patients in a variety of clinical contexts. That students will recognize their own spirituality might affect the ways they relate to and provide care to patients. So it brings it down to that relationship aspect. And then being aware of the need to respond not only to the physical needs that occur at the end of life and in life in any illness, but also the emotional, social, cultural, and spiritual needs that occur. So that's the biopsychosocial spiritual model. So once we had this, we then, GWISH was formed. I continued the work in the 90s with NINR, an organization that received that grant from Templeton. Dave Larson was one of our original lecturers in 1992. And then once we formed GWISH, we ran the awards programs until about 2005, I believe, 2006. Now there's theory and there's evidence that continues to be built. This is a very difficult area in which to create an evidence base. It's hard to measure spirituality broadly defined. A lot of the earlier studies have to do with religion because it's fairly straightforward to ask about denomination, frequency of attendance, frequency of prayer, but it's hard to develop studies that really adequately address the full spiritual dimension of the person. I mean, in palliative care, there's been more research in this, and many more people are doing research now looking at spirituality broadly defined. But you know, when we started these courses, that was not always the case. Nonetheless, so a lot of these studies are association studies. People who are religious tend to live longer, tend to recover better. People who have a high spiritual well-being have these health outcomes. So there are these types of association studies, which are still important. A lot of our guidelines are based on association studies, but they're not a cause and effect. So there's a big call now on trying to do research that moves a little bit beyond these association studies. So number one, there are ethical guidelines that mandate physician attention to all dimensions of the patient's suffering, psychosocial and spiritual as well as physical. And that's from the American College of Physicians in 2004. So physicians are required to do this, and it's an important message to give to your students and model as well. Research that shows that there's an impact on quality of life, coping, recovery from some illness and surgery. So looking at the importance of spirituality and or religion in terms of health outcomes. And then surveys that show majority of patients want us to address spirituality in their care. And I think one of the best studies was from a family practice group in Ohio, McCord et al., who did a very detailed survey, not just saying do you want it addressed or not, but under what circumstance. And in that study, 95% of the patients said if I was seriously ill or dying. 85% being admitted to the hospital for any reason, 60% at each annual exam. So, and there were some others in between that. So I think it's important, it's a very good study in that regard. They also looked at why, and patients said because it increases the trust in my physician, it helps the physician understand me better, it helps encourage realistic hope. So I think these are important, that's a very important study to use for that category. Now, I mentioned that in 2009 we did a conference on interprofessional spiritual care, and the overall recommendations were, and this was based within palliative care, but again, from the start of diagnosis. The National Consensus Project, Diane Meyer and Betty Farrell, and co-led that in the early part of the century, looked at what are the required domains of palliative care, and domain 5 is religious, spiritual, and existential domain. And they recommended that everybody get a spiritual screening. But what was not developed in that conference was who does that screening. So Betty and I developed this conference to dig in deeper. So what does this really mean? What kind of a model is it? What is our role or not, etc. So the overall recommendations is that this model is integral to any patient-centered health system. It's based on honoring dignity, on attending to all of suffering, that spiritual distress be treated the same as any other medical problem, so that we should all be attentive to that. And if I identify spiritual distress in a patient, I need to be responsible for attending to that in the best way possible. There are studies now coming out that pain can be impacted by emotional distress, social distress, and spiritual or existential distress. So a pain scale, score of 9 out of 10 may not be all physical. So we need to treat the other domains as well to have good pain management. Spirituality should be considered a vital sign. Jimmy Holland here, New York, and others are looking at these broader vital signs. That is interdisciplinary, and we need trained chaplains as part of the team, integrally part of the team. That all patients should get a spiritual screening or history, and that we then develop a whole person treatment plan, and that's the biopsychosocial spiritual model. So we are actually teaching that whole person treatment plan now with our students. We have for years been teaching this Oliver Mann case has been published on, my colleague Jim Blatt developed that. And Oliver Mann, there are I think 3 different colors of Oliver Mann. There's a red, a green, and a blue Oliver Mann. And each Oliver Mann has colon cancer, but each one has a different background. Age, goals of care, family situation, spirituality, all of that's integrated. And students work on those Oliver Mann cases and then try to develop, then they have like that one student is the surgeon expert, one student is the other kind of expert, and then they try to come up with a treatment plan. So right then and there, they're already thinking about this whole person treatment plan, which we've integrated more recently. Now, as I mentioned before, it's all of our responsibility to listen to patients' issues, identify distress, as well as support resources of strength. So everybody on the team needs to be able to do that. This is a little bit of a complicated slide, but at the time of this conference, the need was for a model of who does what and where, and when does the person get asked about spirituality. So on my left, on your left, the spiritual screening in the box, whenever a patient is given a screening of any kind, there should be 1 or 2 questions about spirituality. And the goal of that screening would be, does this person need an urgent chaplain referral now? Now, I understand that you have a lot of chaplains. I don't know that chaplains see every single patient that's admitted. There are some hospitals where that's true. Very few hospitals where that's true. But there are some hospitals where that's true. And I'm very envious of that. But in most places, like in our own hospital, we have 1 full-time chaplain and the rest are per diem chaplains. So they can't really see every person that's admitted. So the screening is really to see what is urgent that we need to do now. And George Frechette has a rush model, and now there's so many other models coming out as chaplains are getting involved in research as to what would be the 1 or 2 questions that clinicians could ask for the screening. Then when they see the rest of us, they get a history. So those of us that develop treatment or care plans, usually the physicians and nurses, would do a little bit more than a screening, not as much as what chaplains do though in an assessment. And the history would be part of the regular history that we do. So for medical students, we do it as part of our social history. And again, I'm always battling that a social history does not only mean what do you drink, smoke, or take drugs, which unfortunately, when people are pressed, that's all they ask. But it is the social history that we usually teach about who you are as a person, your significant relationships, your sexual identity, are you sexually active, what's going on in your relationship, your occupational history. Then I add wellness, exercise, nutrition, how do you take care of yourself? A question about domestic violence and safety, and then also a question about spirituality. So that's usually where we put the spiritual history. Those people that always can see a board-certified chaplain, they would do a full assessment. Or if we refer to a chaplain, the chaplains do a much more detailed spiritual assessment. It's not a checklist, it's a conversation. And then in interdisciplinary rounds, the chaplains as the experts. This is for those of us who are lucky to work in interdisciplinary rounds. I co-direct our outpatient supportive and palliative care clinic in oncology. We get an hour with a new patient. All of us interview more together. It's great. But not everybody's lucky to do that. If you're in an IDT team rounds, it's easy, it's easier. You can all talk about the whole person, and all of us can bring up all sorts of issues. Chaplains bring up physical issues and emotional issues, and people on the team that are more expert in each of these areas can contribute. If you're in the outpatient where you don't have IDT, or if you're in a hospital where there's no interdisciplinary team, it becomes a little more challenging. But that's where the note is so important. Everybody should be documenting, because that's where a lot of the communication occurs, where I might say something in my note, the chaplain reads it, they make a recommendation as to what I can do, and back and forth. Or we can talk to each other in person, which is my preferred method, find someone in the hallway and talk to them about that patient. The treatment plan should include spirituality, there should be outcomes measured, there should be a reevaluation, and everybody on the team should be doing that. The bottom line is what I'm going to talk about towards the end, which is that we need our own personal and professional preparation to be able to engage in relationship. So one of the things we talked about at this conference was the dotted line, the transformative interaction. There really is a transformation that can occur between the patient and the clinician. And all of us that interact with other people, we can be changed, we can be transformed in that encounter. Spiritual transformation is a very hot topic right now. I'm going to be speaking next week at the British Association for the Study of Spirituality, and the whole theme is on spiritual transformation. Our global network in spirituality and health is involved in that as well. But looking at, I think it's very simply how we grow, continually grow in our own inner lives, and our patients, or anything that happens in our lives, impacts our own spiritual growth. So that's the recognition that we enter into a relationship, and it's an ongoing relationship that we have with that person, even if it's a one-time visit. So what do we need to prepare for that? Spiritual distress, I just want to show you this one study, that this is in cancer patients, but it's true in anybody getting a significant diagnosis. 73% of cancer patients have at least one spiritual need. 40% of newly diagnosed cancer patients have high levels of spiritual distress. So very important, we're now doing some work with our survivorship clinics too, to make sure that spirituality is integrated in that. And then there's studies that show that people with low levels of spiritual well-being also have significant spiritual distress, including hopelessness and a desire for hastened death, despair. So again, very important that we address that. In this conference, and I'm happy to share this paper with you, I can email it to anyone, but we then in this conference used the National Cancer Comprehensive Network spiritual diagnoses, as well as others from other parts of the literature, to propose what these spiritual diagnoses might be. And you can see it ranges from existential to abandonment by God, or others. If people have others, they consider their significant spiritual others. Concern about a relationship with the deity, which I also would like to say just an inner journey, if people want to deepen their own inner journey. They might have conflicted belief systems, and those can be any kind of belief systems, religious, cultural, inner belief. I have many patients who are naturalists who get very, very depressed when they get cancer, or any other kind of illness. I eat so well, I have natural foods, why is this happening? I live an ethical life, why is this happening? So that can cause a lot of distress. We did these charts to show what a key feature from the history might be in example statements. So we use some of this in our courses in spirituality and health. And the diagnoses also include hopelessness, despair, bereavement, grief. The need for forgiveness and reconciliation are often themes, particularly with advanced illness. And then some isolation, be it from a religious community or whatever that spiritual community is for people, might cause distress. So we did a study with Joel Sabat from Cincinnati. He's an HIV expert researcher. This was in 2003 or 4, I think. And we were interviewing patients, doing all sorts of instruments. And we found that while many of our patients with HIV/AIDS were identified with a religion, they felt very isolated because of their illness. They felt rejected by their community. And so they had a lot of distress from that. They wanted to go to that community, but the community, in their eyes, was not welcoming them. I'm hoping things have changed since then, but that is an example of a lot of distress. I have a lot of older patients who can't go to their religious communities or other types of spiritual communities anymore. That causes them a lot of distress. So when we look at spirituality, and this is the way that we teach it, is that we need to use a discernment process that we use with anything else. In the same way that students need to discern this person is having chest pain, where is it coming from? And they need to know to ask questions that might rule in or rule our cardiac disease, pulmonary disease, gastrointestinal, reflux, musculoskeletal, anxiety, etc. They also need to be thinking about that for emotional, social, spiritual issues. So if a person's in distress, where is this coming from? Is it physical predominantly, emotional, social, spiritual, or a combination? And then who on the team needs to be involved to adequately help provide the best care for this patient? So if there's spiritual distress, we need a chaplain. If it's in the outpatient setting, pastoral counselor, spiritual director. Maybe the person's clergy is someone they would look for. So, and then in the model, we talk about what is it that we non-chaplains can do. And so George Hanso helped us develop a concept, which I think is not simple at all, but the simple things simple spiritual issues that we could deal and complex that definitely need a referral to a trained chaplain. So there's a little bit, less so now, but there's a little bit always, argument about, are we pathologizing spirituality? Well, I think it's important to recognize that people can have spiritual, religious, or existential distress. And in my experience of doing this for so many years, if the physicians and the nurses are not identifying it, even if the chaplain identifies it, it gets ignored. And this is here and globally as well. That is why it's so important that all of us do it. It somehow becomes less important. And I think it's the same with social distress. Oh, there's a social worker on the team, and it's not that important, but it is that important. It may be the most important thing. So it's very important that we take these things and use them, as I said here, practical, accessible, familiar frameworks for physicians and nurses. Language that we can understand, so that it's not too philosophical, theological, etc., but it's within the context of how we interact with our patients, so that we are sure that we address all types of distress. So in this Improving the Quality of Spiritual Care as a Dimension of Palliative Care, the 2009 meeting I did with Betty Farrell, and many colleagues who were involved, including chaplains, was very diverse, all disciplines, etc. Assessment and treatment of spiritual distress, and include spiritual distress in symptom management. I'm asked, actually, for myself in our clinic, we have a review of systems question for spiritual or existential distress. Identification and support of resources of strength, and we do that if a person has strong family support, we write strong family support, good resources. Person exercises, this is a strength. Person has strong beliefs, they meditate, they do yoga, whatever, they have a strong community. That should be noted in the chart. I mentioned the general specialist model. We need to provide compassionate care, and then we need training commensurate to the scope of practice of all of the healthcare workers. So the Marie Curie Institute in England has done that type of training. They have competencies for people from volunteers all the way up in the team. Now, the spiritual history is really an invitation to the patient's story. It's not a checklist. It's not, when my students say, I've done a spiritual history, the person is, say, Muslim. Well, that's not a spiritual history. That's a religious identification, but that's not a full spiritual history. So it's really an opening. We've developed a tool called FACP, which has been validated. We're now doing a lot of studies in different countries, translating that tool, which is turning out to be quite interesting in terms of cultural dimensions. There are other tools as well. So we learn what matters most to the patient, we identify their resources and of strength, and then identify distress or suffering. But also, because of the nature of this conversation, we should really be fully present. And many times when I've done this, if someone has spiritual distress, and I am open, and we all have to be open in these conversations to being present, that is often when that conversation occurs. Now, the treatment plan, just to give you an example, this was a patient of mine with end-stage ovarian cancer. I would have written a lot more in the narrative part, but I just want to show you how this would look in the assessment and plan. Her pain is well controlled, continue with the current medication regimen. She had some nausea and vomiting from her small bowel obstruction that could no longer be operated on. We added our triage to her regimen. emotionally brief reaction that her fight is over, very tearful, difficulty sleeping, but she has strong coping skills and a good support system, so supportive counseling, continued presence. She's really, in terms of her social, she's very concerned about how to tell her family that she's dying. Her parents, she was raised in an Orthodox family. She was not Orthodox as an adult, but she says in our belief system, parents, children don't die first. And I don't want to cause pain to my family. So she's very worried about telling them now that her disease has progressed and that we're going to be making a hospice referral. So while she has strong family support, there is this issue about causing pain, and so we worked with a social worker to arrange a family meeting. At the time that she was in the hospital, we really didn't have a chaplaincy program yet, sad to say, at that time. So I would have engaged a chaplain in that family meeting as well as a social worker. Her assessment, spiritually, she was at that moment in time was very hopeless. Her main source of meaning was in winning the fight. That was gone. So this is where she had to start looking for another sense of meaning, that ultimate meaning, because her main source of meaning was over. She just did have strong spiritual coping skills. Her husband died unexpectedly a year before she did, a year and a half. And though not very religious, she now says to me, I'd like to learn how Jewish patients die. And some people have heard me tell this story. She was so, I thought, anti-religion that I kind of did my research, came in the next morning with some ideas, and she sort of smiled and said, well, with all due respect, I do need to hear that from a rabbi. So I learned about making assumptions. And so, but this is so Rhonda, I loved her. She interviewed many rabbis, and then she found one that she loved. And he ended up, I went to her service both right after her death and a year later, and he was an amazing, amazing person. So we also worked on legacy building and a dream list, and she actually asked me to write my list, and she knew I hated to do artistic things, so she asked if I would write it and do some drawings, and I said, oh my gosh, she goes, please, that's my wish before I die. I'm like, okay, I'll do that. So she was a very interesting person, but see, the relationship that builds, I took care of her for a long time, and having that relationship. But the idea here is, again, having every clinician be thinking in this domain. You may not write very much, but at least, be addressing it. So the dotted line, one of the things what we talk about with this transformative interaction is a healing encounter and shared decision-making and partnership. So we're not just handing a treatment plan to the patient, and their family are a part of that. And I want to switch to this last part, which is this role of this inner development. I think compassionate care, I like to think of it as a clinical dance of science and spirituality. So we do need to be very scientific when we're assessing and diagnosing. We ask questions. We have to be very clear about the questions we're asking, be very thorough. And I tell my medical students you have to have a little bit of obsessive compulsive disorder. Make sure you ask everything and explore everything. But at the same time, we need to know when to be reflective and move more into that reflective and compassionate mode, more overtly compassionate, and that's the silence. So that if a patient says, and when I'm getting a family history from someone, and this is a true story, a patient, I asked about her mother, and she says, I don't really know very much about my mother's health because she died when I was 7, and then a tear comes up, and then I find out that, well, in asking about her dad, I don't want to talk about it very much. He was very abusive. So now this very reductionistic family history about medical illnesses becomes an opportunity to listen to her story more deeply. That's what we have to learn how to do so that we can shift between those very easily. And this is actually some of the things I love most about medicine, is being able to discern how to do that. The competencies, what we did is we framed our competencies around the ACGME competencies, but we added compassionate presence as its own competency. And some of the concepts were the clinical ones about spiritual history assessment and plan, the diagnoses, but also looking very deeply at this one competency on compassionate care. And the recognition, and this is published, and I can share this paper with you too, it was much more than my slides, the recognition that we need formation of students to be able to do that. Now, prior to this conference, at least in my circles, we didn't talk about formation of students. That was in fact, I mentioned it, and they said that sounds too much like seminary, things people do in seminary, formation. But we do have formation. We do need to be formed. We're doing a different kind of a formation. You know, you wear your white coat. You can't have sex with your patients. Here are the ethical guidelines. This is what you need to do. That is a formation of a professional identity. But the group that did this with us called on a deeper formation, an inner formation. So just to give you a couple of examples, there's many more. We then, under each competency, describe behavior, so performing a spiritual history and follow-up of distress, integrating issues into the treatment plan, making timely referrals to spiritual care professionals. And for the compassionate presence, explain the reasons that, under personal professional development, explain the reasons that drew you to medical profession, explore the role of spirituality in your professional life, reflect on signs of your own spiritual crisis, identify your resources of strength. So that's the personal and professional development competency. And then the compassionate presence one that was created. Discuss why it's a privilege to serve the patient. Describe your external or personal limits, factors that limit your ability to be present. Describe strategies to be more present to your patient. And describe how you can be changed by your relationship. There's many more, but I wanted to just highlight those. We have done a frequency of competencies. For our Reflection Notes project, we had about 30 medical schools applying. And part of the requirement was to fill out what they teach. And the majority of schools were teaching to these competencies. I'm just going to give you the top ones. So the number one was describe strategies to be more present with patients. Discuss the relationship between spirituality, religious beliefs, and culture. Perform spiritual screening. Appropriately utilize the patient's spiritual network and resources. Practice deep listening. I was thrilled to see that that was one of the top ones. Practice curious inquiry, a non-judgmental practice of exploration without goals or expectations. So you're an ICU doctor or nurse. You have moral distress because of the way a patient is being treated towards the end of their life. The doctor or whomever on the team talks to the family. The family says, I believe in a miracle, continue this care. Okay, so we do have a little bit of a goal in that, what we think may be in the best interest of the patient. But in that particular conversation, it's really important to be non-judgmental and to not criticize the family for that belief and not to set up a science versus religion kind of battle. Our chaplains are very good in this conversation, but we also need to not have a goal. Just tell me more about belief. Tell me more about your loved one and, you know, trying to, of course, get to the point of what their goals might be. But really, first, just exploring. And that goes with everything. And we should have that with anything. Any kind of question we ask should be non-judgmental. Describe how patient spirituality may affect their specific clinical care, their perceptive reflections, demonstrate use of silence, and then a detailed spiritual history. So those were the top. So our reflection rounds, I mentioned already about healthcare. It's relationship. Basically, we're journeying throughout this. I remember as a medical student, someone who was dying was moved away from the nurse's station to another room and to be alone. And I think so many people, suffer in silence, and they need that presence. Quotes from medical students: caring for Miss Lee made me aware that I too will die one day. It's too hard. What do I do if I feel sad? Do I cry? Is it okay to cry? Clinicians, same kinds of issues. Time management. I have no time left for me, no time left for the patient. So we know that physician suicide rate is the highest of all professional groups in this country. 12% in male depression, 12% male female physicians, and 15 to 30% in medical school surveys. And if you just look at some of the studies, Pamela Wimble did this study, why physicians commit suicide, you will see up there that much of that has to do that we're not practicing out of our vocation. And there are other things too about spending time with family, etc. Doctors being emotionally detached. That's why I bristle a little bit with the word detached. So I think spirituality, again, as I mentioned before, is such a key part of our vocation. So in our 2009 conference, there was a requirement that spirituality be part of personal and professional development. And these are some of the things that they recommended healthcare organizations should have and medical schools should have in their curriculum. And so I just want to close with the reflection rounds. We recognize that a completely formed physician is formed around two paths, not just the biological, but the psychosocial, spiritual as well. Our rounds are called rounds to make it valid and equal to all the other rounds. It's not just a nice event in the evening, but it's part of regular rounds. We had an RFP. We now have 18 schools that have piloted this, and we have outcomes. We're working now at other levels as well. It's a very simple, in a way, outline. It starts with an opening ritual, check-in with students. Students share their reflections. We use a modified chaplain verbatim to do that. And then there's a closing ritual. The features are the chaplains and medical mentors. So for physicians, it's medical students, it's chaplain and physician mentors. And it's just like any other type of excellent facilitation with this regard, that you create a safe environment. But the type of facilitation is very different. It's what many of you know who know spiritual direction. It's a little bit like with spiritual direction. It's a deeper inquiry into the inner story, not so much teaching and highlighting and staying up in the head. Our students love it. They just live for the session. Every school, the students say, we need more than 4 a year. We need to do this more often. I feel listened to. And what we found as a byproduct of all of this is that the students see how deep listening is modeled, and then they start doing it when they ask the questions of their colleagues. And many, even after a couple of years, they say they use that kind of technique with their patients. So we feel that this is a very successful project. I know we're running out of time. I just wanted to tell you at GW, we have formation throughout the 4 years now. It's in small groups, and the mentors that do this are specially trained. We have a lot on boundaries, self-care. Spiritual history is integrated as part of the clinical, learning how to do social history. It's in there. They learn about spiritual distress, working with trained chaplains, and it's integrated in a lot of different courses, from anatomy on through the 4th year. So in summary, spirituality and health courses are person-centered focus. Models exist that are integrated and required in the curriculum. Competencies are created to standardize the field, and reflection is found to be a good methodology for teaching and for professional formation. So I've shared a lot with you. Thank you so much for your attention.
Thank you very much. That was very rich. We do have some time for some questions, and we have a microphone that will circulate. And while we're preparing for that, if you have any questions, Yael, it's yours. We'll bring you the microphone.
Good morning, and thank you for a wonderful presentation.
Okay.
I'm still hooked up on the role of silence that you just spoke about, and understanding what it means, isolation in the case, but also the role of silence in the hospital environment itself. It's one of the noisiest places that I've known, and I've encountered so many patients who want to experience silence, both inside and outside. But outside, nurses are busy and chatting and talking and all that. So how to integrate the understanding of what silence as a value, as a spiritual value, in the treatment of patients?
I'm going to answer that with a quote first. Henry Nouwen wrote this quote: "Listening is much more than allowing another to talk while waiting for a chance to respond. Listening is paying full attention to others and welcoming them into our very beings. The beauty of listening is that those who are listened to start feeling accepted, start taking their words more seriously, and discovering their true selves. Listening is a form of spiritual hospitality by which you invite strangers to be friends, to get to know their inner selves more fully, and even to dare to be silent with you." So you can do this in a busy hospital. It's really what happens between you and the person that you're sitting with. A lot of what we do is that we are anticipating our next question when we hear someone sharing their story. And so, number one, and he says that in this quote, number one is, this is what I do in a hospital. The clinic is, quite frankly, just as loud because the walls are kind of thin too. But I take a breath myself before I go into the room, so that I bring myself into that focus, that I'm going to exclude things and I'm going to really focus my attention on that patient. So people who do mindfulness meditation can do it with the noise. In fact, that's some of the training in many of the religious traditions, right? So it's that kind of, that's what you do first. The other is to train ourselves to turn off that reduction. So I need to do that as a doctor, because in the other part of the interview, I'm always thinking, this is the information, what's my next question, right? So I have to change that mode of listening for that period of time where I think that person wants to be heard deeply. And so turning off that question and really just focusing and not saying very much. So I provide the silence for that person. And if the patient doesn't say something right away, I don't bounce in there and try to fill the space. Sometimes we sit together in silence for a minute or two. And usually that spiritual hospitality that invites them to share more. So does that kind of answer your question? It's really, I think it's important. The second part of your question is they're looking for a space of silence. You know, I heard of a hospital in India that was designed around that principle. I mean, I saw pictures of it. It's circular, it's not rectangular. The way the rooms are done, they have it so that it's quiet. Many places put up quiet, don't disturb patients, but they actually take that seriously. Spirituality is just such a part of Indian culture that it just, I mean, I haven't been there, but it sounds like that would answer your question better. But this, you know, we start with the best that we can do. Yeah.
My name is Tanya Pagan Rajo Ashley. And first of all, I want to say thank you, because almost 20 years ago, I was working with others to develop a curriculum for students, and I used a lot of the information and articles that you had to help the students, number one, with their formation, to look within themselves and where they stood in terms of their spirituality and beliefs before they could even get to the next step to interview the patients, and it was very helpful.
Great.
The second is I wanted to share something with you which I found very helpful as a physician. Even though I had co-developed that course, years later I married a pastor. And I thought I knew what I was doing. And I had no clue. In retrospect, I really didn't have any clue what I was doing, because I actually went on rounds with him one day, soon after we were married, and this whole world opened up. I mean, and I think what you indicated in terms of having the students go on rounds and whatnot, and sometimes having, whether it's a pastor or rather an imam, as the mentor, as the expert that they follow, if they're allowed within that world, it is an amazing difference. And it helped me years later when I had the opposite situation of what you spoke about in terms of the patient, of the families wanting to prolong the patient's life, where I had an aunt who didn't want her life to be prolonged after a catastrophic event, but we had nothing in writing. And it was actually working through with the rabbis and the pastors, and then helping me to formulate a letter on behalf of my family, her sisters, and bringing it to the ethics committee, that they finally took her off of her bed, which is what she never would have wanted. So I think there's a lot of different places where it can be very, very helpful to fulfill the wishes of the patient when he or she, or however they identify, can't speak for themselves. So thank you very much.
Well, thank you, and thank you for your comments, and I'm really impressed that you were doing the formation 20 years ago. There was such a resistance. That's great. No, I know. We all do a little at a time. And to also say, so clergy, you talked about clergy specifically, so clergy are great resources for students, and I neglected to mention faith community nurses also, who do a lot of this work. And then, and chaplains, we have integrated, so not all chaplains are clergy. They do have, I think it's still the same, they have a requirement for getting like a master's in divinity or some sort of theological training, because I think that kind of training is important, whether you work with atheists or agnostic. They have different training, as you said, than us, and I think that's really critical. But they are trained within a healthcare setting, and even in the 90s, we had practice of medicine groups, like Doctor-Patient Society, it's been called different things at different medical schools. It used to be mentored by an MD, like a physical medical doctor, and a psychosocial, which could be a psychiatrist or a social worker, and then we started having trained chaplains be the co-mentors for those groups. And it was phenomenal, because they were able, their training and understanding of theological concepts, which are, that kind of training helps you understand spiritual broadly defined too, and how to inquire about that. Their training in clinical pastoral education is superb, and I think it really helps with that kind of reflection and inquiry, and they practice that with the students, and it really made a difference and continues to make a difference. So yeah, absolutely. Thank you. Thanks. Yeah.
Yes, just a little concern. Most of all, we know the importance of spirituality on the overall care of patients, but as you mentioned also, most health organizations don't understand that. And they don't really understand the importance of involving spirituality. I think that one of the reasons is that the art of medicine that started to be a healing practice has become more a symptom management practice. Mm-hmm. So what things we can use, if there's any studies or anything like that that we can create or advocate, create consciousness on health organization of the importance of spirituality.
So there are many studies. There's a very good study recently from Betty Farrell's group that shows that it was a controlled trial where one group of family and family caregivers received a spirituality education module out of 4 training modules, and the other one did not have that. And the ones that had that had better, both sets had better quality of life, spiritual well-being, better psychological parameters. George Fischette and his colleagues did a analysis of several patient data sets and showed there, again, these are association studies, but it's enough to get at what you're trying to say, that showed that spirituality and or religion excuse me, results in higher reported better health. The patients reporting that their health was better, lower depression and anxiety, and better improved patient experience and patient satisfaction in spiritual care. So I think it's, Tracy Balboni has done a lot of really good studies, mostly in palliative care, but this area now is growing. There's an excellent researcher in England. She's part of our global network in spirituality and health. Just to tell you, the Global Network is the first international organization having to do with spirituality and health and spiritual care. There's another one in Switzerland specifically on international spiritual care that does research. So both of us have big research components that have to do with, not me personally, but others around the world that are doing research. So Lucy Selman is an excellent researcher in England, Shane Sinclair in Canada, and there's many. If you look at GNSAH, the global network, and you're all welcome to sign up. But we do have an online platform now where people are sharing those resources. There's a really good effort, I believe, the Spirituality and Health Institute here is doing a focus on that, on chaplains being involved in research. So George Fischette is a chaplain and a PhD epidemiologist and is leading many programs on, for example, adding a research awareness training and chaplaincy programs so that chaplains can find those resources, for example. But also chaplains are looking at chaplaincy outcomes. And those are very important because I think having spiritual care outcomes for all disciplines, though, will speak highly. There are requirements, actually, though, with JCO and other requirements that a patient's spirituality has to be addressed. Where I'd like to see those requirements move those, that it's not just the chaplain or that someone asks it on some form, but that everybody on the team does it and that spiritual distress be treated. And so that's why some of our studies and others on spiritual distress is really critical in showing that. So in oncology, for example, for palliative care for generalist oncologists, in other words, not palliative care oncologists, but just in general, what do you need to ask your patients? What you need to know about your patients. There is one item on faith. Unfortunately, they don't, because faith has been studied and not spirituality. They don't have a broad one on spirituality, but we're working on that to enhance those guidelines. So there are guidelines in places, and you just have to find those, and I'm happy to send them to you. Our 2009 report was used in the Institute of Medicine Dying in America. So there are guidelines in place that say that patients need to have their spirituality addressed. And again, if you're, for physicians, American College of Physicians talks about attending to suffering. I think it's just going to take a concerted effort. It's going to take more data, and it's going to take a lot of policy work, which is what we're working on.
Thank you.
Great. We are fortunate to be one of the recipients of those grants from George Fischette to integrate research literacy into our clinical pastoral education training, our residency program in particular. So we are a beneficiary. And a beneficiary of your time and expertise today. So thank you very much. This has been another one. As we conclude, let me just remind you again that we're accepting applications for our CPE program. Please direct people to us if they're interested. Our next Grand Rounds presentation will be Friday, June the 17th at 9 a.m. If you need CMEs or CDs, please be sure to return your Grand Rounds evaluation form as you exit. And again, chaplain residents and fellows, return here at 10:30 for a follow-up discussion about the Grand Rounds. Thank you, everybody. Have a great day.